Good morning, everyone. Welcome to our Grand Rounds today. I just wanted to have a couple of housekeeping issues before I introduce today's speaker. We want to ask you to please submit your questions throughout the presentation if you wish to submit them in writing using the Q&A function of the platform here. Don't use the chat function if you can avoid it for the questions, and submit them through the Q&A. Leave the chat function if you have any technical issues, or of course, if you want to chat throughout the presentation. So we'll be looking at the Q&A. And at the end of Dr. Hayes' presentation, we'll also be opening the microphones. If you wish to ask a question live, just raise your hand and we'll call on you and we'll be able to then unmute yourself and ask your question. So without further ado, it's my distinct pleasure to introduce today's Grand Round speaker, Dr. Sharonne Hayes. Dr. Hayes has received her medical degree from Northwestern University in Chicago and pursued fellowships in internal medicine, cardiology research, cardiovascular diseases at Mayo Clinic in Rochester, and joined the Mayo staff in 1990. Presently, she is a professor of cardiovascular medicine who founded the Mayo Clinic's WomenHeart Clinic in Rochester, Minnesota, a place where I had the chance to train and learn. Dr. Hayes has long advocated for the advancement of women's health and sex-based medicine within the field of cardiology and many other areas that affect women's health and well-being. Dr. Hayes previously served as Mayo Clinic's first director of diversity and inclusion for a decade between 2010 and 2020. And with leadership, she set strategy for diversity and inclusion activities across the Mayo Clinic and developed solutions for, my page didn't turn. She developed solutions for equity in patient care and in the workforce. She also has directed the Mayo's Office of Women's Health, has led efforts to optimize women's health clinical practice and research activities at the Mayo Clinic, and develop programs to enhance the professional and personal development and mentorship of women as well as minority physicians in order to promote a more diverse workforce in the field of medicine in the Mayo Clinic and beyond. In 2017, she was recognized by the American Heart Association with the Women in Cardiology Mentoring Award. She is a tireless advocate for safe, equitable, and dignified healthcare workplaces that promote high-quality patient care and has developed programs to assess and mitigate unconscious bias in healthcare. Dr. Hayes is a member of a number of national initiatives and groups involved in education, strategic planning, and program development for improvement of healthcare and reduction of health disparities. She helped develop the NHLBI's Heart Truth, which you know as the Red Dress campaign, is active with the American Heart Association's Go Red campaign, and served on the board of directors of WomenHeart, the National Coalition for Women with Heart Disease. Her commitment to women's heart health has been recognized in 2002 with the Wenger Award and an invitation from First Lady Laura Bush to speak at the White House for the first National Wear Red Day in 2004, as well as a Women's Day Magazine Red Dress Award in 2009. Dr. Hayes' research interests include sex and gender-based cardiology, cardiovascular conditions primarily affecting women, SCAD, fibromuscular dysplasia, health equity, participation of women and minorities in medical research, healthcare workforce equity, and the utility and optimal role of social media in clinical practice, medical research, and health education. As you will experience firsthand today, Dr. Hayes is a nationally recognized educator and speaker on diversity, women's health, and cardiovascular issues, and she has developed numerous medical education programs on women's health and health equity topics for both medical professionals and the public. So without further ado, I'd like to call Dr. Hayes to give us a presentation today, and she can speak on a number of topics, but today's focus will be on SCAD, novel insights into this not so rare condition. Dr. Hayes, welcome to virtual Ottawa.
Oh, well, thank you, Thais. Dr. Coutinho, I appreciate the invitation. Wish I could be there. We have similar climates, so it certainly would not be a shock to my system. And as we kick off, I'm going to share my screen here, but as we kick off, I'm just going to make sure I can see all of you. As we kick off this program today, I'm thrilled to be here and to talk about this topic for which I have a really strong interest, and for which there has been a sea change in the way we think about and care for spontaneous coronary artery dissection. So I'm actually going to start with a little bit of history and then bring you forward and then give a few clinical pearls, because I see a lot of these patients, and they have some unique issues. So let's, in terms of, I don't have any conflicts, and I will start with, I am not an interventional cardiologist. You did not see that in any way in my bio. And I'm not going to show you any cine angiograms either, but I am going to show you how to diagnose SCAD, whether you are an interventionalist or not. So if we go back, and I said we're going to talk about historical, and first of all, I want to acknowledge that you in Canada have a rock star on this topic, Dr. Jackie Saw at Vancouver General, and she and I have collaborated on a number of things. But if we go back, we believe that the first report of SCAD was back in 1935 in a 42-year-old woman who was retching and at autopsy had both aortic and coronary dissection. I was not practicing medicine back in the 50s, but I was into the early 2000s for sure. And this was the rubric that those of us who were taught in cardiology school about SCAD, one, we were told it was rare, extremely rare. We would probably see only a couple of cases in our practice over a lifetime. It was felt to be about 70% women, not the current 90+%, and that most of them were peripartum. Most of the reports were case reports, and many were autopsy series. So it led to the impression that most of these individuals died, and in fact, surviving SCAD was reportable. Multiple associations and causes were put forward. Many best treatments, everything from CABG to thrombolysis to PCI to observation. One of the challenges with the earlier literature, and I would caution you whenever you're referring back to anything much before 2010, is the SCAD definition was inconsistent and often included procedural dissections or clear atherosclerotic dissections, not pure spontaneous coronary artery dissections. And there were some early reports of triggers or spontaneous healing. This is one of my favorite finds in the old literature in 1994. It was the first English language report of exercise as a trigger for SCAD. The language is a bit dated. It was a housewife and she was doing unusually severe exercise, but she did experience a SCAD. And so that was kind of where we were. And as Dr. Coutinho indicated, I have been involved in WomenHeart, the National Coalition for Women with Heart Disease, for many, many years. And they have an online platform. And I do a training program annually for women with heart disease who then go on and form support networks. And in 2009, two of the women attending this program came up to me at a coffee break and said, you know, what's Mayo Clinic doing to study SCAD? And I kind of puffed up and I said, well, I know more than the average person because, you know, I run a women's heart clinic. And, but I went on, I said, even a Mayo Clinic couldn't study this. It's so rare. They let me go on and then reeled me back because they said, well, you know, on WomenHeart's online community, there's about 70 women with SCAD. And we have come up with a research agenda. Now, at the time, I was not giving SCAD much thought at all. And I went back that night to my office and did a literature search. And at that time, the largest case series was about 42 patients. And I had just heard them say that they had collected. But remember, this is an online community, and trying to figure out how to leverage that online community for a rare disease research was the biggest challenge, honestly, because we did not know where they were. They had screen names. We didn't have an email address. So anyway, we spent some time and ultimately were able to test the methods to do a remote or virtual registry. So, and that goes on today, and I'll talk about that later. So flash forward, SCAD finally warranted a scientific statement from the American Heart Association and several reviews that have been collaborative across countries and organizations. So what do we know now? So I think the point you're going to hear me make multiple times is that making the diagnosis properly is so important because the care is different and the prognosis is different in SCAD compared to atherosclerotic or other types of myocardial infarction. The demographics, so the average age is 42 to 52, but we've had teenagers up to people in their 80s or so who have had SCAD. It is not 70% women, probably 90, 95% women, and only about 5 to 15% are in the peripartum. I think we were missing, and we'll get to the missing part, but we were missing those who were not peripartum. I think there was an index of suspicion in the postpartum woman presenting with myocardial infarction. Cardiovascular risk factors are uncommon, but important. They're not necessarily absent. And in fact, hypertension is present in these women at about the same rates as in the general population, lower than those presenting with atherosclerotic myocardial infarction. And again, it was not rare. What all of us who trained before 2010 that were told it was rare, it is perhaps uncommon. It is less common than atherosclerosis. It probably represents 1 to 4% of all myocardial infarction. It's the number one cause of pregnancy-associated myocardial infarction and the number one cause of myocardial infarction in women less than 40, and about 7% of myocardial infarction in women less than 50. So particularly in those age groups, we have to have a very high index of suspicion. The other thing that's evolved is that we now look at SCAD and we think of it as a vulnerable patient who may have some underlying conditions, such as perhaps some susceptibility mutations, genetic, or fibromuscular dysplasia, or some other systemic arteriopathy. The pregnancy and hormonal and rarely inherited arteriopathies or connective tissue disorders. And then we look at, in some cases, some type of trigger or condition. So thinking about this, because patients want to know, why did this happen? About 25% of individuals describe a trigger of either extreme emotional or physical stress. That means that about 75% do not. So often I just talk to individuals about not trying to look for an underlying cause, but that they have generally more fragile arteries and are more vulnerable. I think the other thing that back pre-current era of SCAD, patients were told either it's no big deal, it's a fluke, you'll be fine, don't even think about this, to you're lucky to be alive, but it'll never happen again. What we know now is probably somewhere in between. It is not benign. SCAD presents as STEMI about half the time, and VTVF about 15%, and about a quarter with multivessel SCAD. We know now that PCI may cause harm, and we'll get into that later, and that recurrence rates are, I've had patients who were told this is a lightning strike, it'll never happen again. Unfortunately, we have to tell patients that it can. And for those of you who have experience caring for these patients, you know that there's significant post-SCAD morbidity, particularly with chest pain. We know that the SCAD-affected artery often heals without treatment or intervention, and therefore we may want to take a different bent on early treatment. And unfortunately, there's no secondary preventive strategy other than good blood pressure control that we can offer patients, which compared to atherosclerotic myocardial infarction is a stark contrast, and one that patients often pick up on. So the other thing compounding the fact that this is a relatively new science, and then the other part is that just like the whole reason that Heart Truth and many of the organizations back 20, 25 years ago were formed was because we were missing myocardial infarction in women because of absent science, but also absence of index of suspicion. And I tell this tale of two sisters. I'll give you a thumbnail. But at any rate, this woman was sitting in my office and her sister was sitting behind her, not my patient. And I heard both their stories. The other sister had had a SCAD about 3 or 4 months prior. She had called emergency medical services. She had been taken directly to the hospital in a major metropolitan area and treated appropriately. Her sister, who lived in a rural Midwest community, went in with pretty bad chest pain, pretty classic in retrospect symptoms for myocardial infarction, said, I'm having chest pain. She also had anxiety as a diagnosis on her chart. She said, my sister had a SCAD 10 days ago. Do you think this could be it? Her troponin was elevated and they sent her out of the hospital for an outpatient evaluation. Long story short, 5 days later, she finally had an angiogram, and at that point had an ejection fraction of 40% in an LAD SCAD. And I could use her name because she's been quoted in WebMD magazine, but there's no way if I was a man, I'd have come in with those symptoms and that I've been turned away and told you just have anxiety. If I was a man, I would have been taken seriously. And I think that still is, if you think about a 20 or 30-year-old healthy looking young woman, a risk in SCAD is because even those who are coming in with very classic, certainly not atypical symptoms, they are often not even managed or assessed for myocardial infarction. So that low index of suspicion has caused us to miss some SCADs or delayed diagnoses. They're young, they're female, they often don't have risk factors, they don't have plaque. And so even if they reach the point of getting a coronary CT angiogram in the emergent setting, SCAD can be missed. I think it's important to note that 80% report chest pain, and more than a quarter of them, it's their only symptom. So I don't have to tell this audience of cardiologists, but perhaps helping our colleagues with who are first responders about this demographic and assessing them for myocardial infarction. The other reason we were missing them is in the cath lab. So they made it to the cath lab, and we assumed that a stenosis was atherosclerosis. And often that SCAD, and particularly the intramural hematoma, was diagnosed as spasm or normal coronaries or Takotsubo. And so I'm going to make the point again and again that making that diagnosis really affects both acute and long-term management. So when we recognize it, I think prior to 2010-12, the way all of us cardiologists were told to diagnose SCAD was look for the intimal tear on the angiogram. And we were missing the intramural hematoma, which probably represents 70 to 80% of the presentation of SCAD. And so it can mimic atherosclerosis, but recognizing SCAD in the cath lab has been has improved dramatically over the past decade, but still can sometimes challenge us. So what we're talking about on the right frame, you see a clear intimal tear. Most of us would have no problem making that diagnosis. It was the medial hematoma or intramural hematoma that we weren't seeing, or we were calling something else. So here you see the IVUS and OCT examples. So Jackie Saw helped a lot with helping angiographers and those of us reviewing by sort of saying some angiographic types. One caution I would use in these types is patients and non-cardiologists somehow think that the type is important in viewing outcomes. And I would argue that the important thing using these types is important for helping with pattern recognition and diagnosis. But in fact, type 2 and type 3 are both intramural hematoma. And there are some prognostic differences from those who present with intimal tear versus intramural hematoma. And that's probably more important than type once you make the diagnosis. So important to make that first initial SCAD diagnosis. Look for the clinical presentation, which is often classic in the non-classic patient. So you have to have an index of suspicion, and then perform coronary angiography with intracoronary nitroglycerin. This is important because spasm and other things can look like SCAD, or you'll miss it. So looking for intramural hematoma or an intimal flap or some other confirmed diagnosis. So you've done the angiogram, you've pulled in a colleague, and you're still not sure. So if safe or feasible, doing OCT or IVUS at the time can be helpful. I think it's important, though, that you don't need to do this to confirm in classic SCAD. Coronary CTA can be performed, particularly if it's a proximal lesion, and can be done after the fact. So sometimes we, because we're a referral center, will often see these folks who they had the angiogram 2 months ago, and now the question is, was it SCAD or not? And so some other, I guess, those things that help balance or tip the scales is doing CT angiogram or other imaging looking for arteriopathy. So obviously somebody with atherosclerosis can also have fibromuscular dysplasia or evidence of carotid dissection, but that might lean you for those ambiguous cases. And then repeating coronary angiography at 4 to 8 weeks. Now, I say this with great caution because these are individuals who are at increased risk for iatrogenic coronary dissections. And so should not be routine, but if it's important to make the diagnosis, that is not an unreasonable thing. The other, particularly in the age of COVID, is these folks may come in and is this myocarditis due to COVID or discrete myocardial infarction, particularly where the angiogram is uncertain. And so cardiac MRI can sometimes be helpful as well. Not to say SCAD, but at least to say myocardial infarction. So when we're in there doing the angiogram, certainly there are some SCAD signatures that have been identified. This was work that was done by a current colleague, but at the time a fellow at Mayo, who painstakingly looked at hundreds of angiograms and measured angles of all of these coronaries and compared it to controls. Over 70% of SCAD patients have tortuosity, where it's about 30% in the general population. So again, it's one of those things that's not diagnostic, but can help tip the scales. It's important to recognize, now that we're all aware of SCAD, that we can overdiagnose SCAD. And so we can miss SCAD with distal total occlusions because we just can't see them, pseudo dissections with contrast screening, or we see the ventricle that looks like a Takotsubo. And so we say it's Takotsubo and we don't look that hard at the coronaries. And so you can see in this, there is definitely a SCAD, but there's a Takotsubo-like wall motion abnormality. So here's a case. So this angiogram patient came in, had an NSTEMI. The initial angiogram read as normal, really clean looking coronaries, but concerned, so did the cardiac MRI, and then MRI showed delayed gadolinium enhancement consistent with infralateral myocardial infarction. And repeat angiography was performed, and what you can see is that's the left frame is the original angiogram, and the right frame was after healing, and all of a sudden they have a branch of an artery there. So again, sometimes this is the way to inhale it. So the reason we give nitroglycerin is because this is a patient who had spasm that was initially diagnosed or thought was SCAD. Fortunately, once we gave nitroglycerin, that plumped up and there's no SCAD there, but in fact, they did have a SCAD in a more distal artery. And so importantly, so some tips, this was an article we published last year with David Adlam, who's in Leicester, who is also doing a lot of work in SCAD, is trying to tip those scales if you're having a tough diagnosis. So there's ambiguous cases, remembering to try to exclude those SCAD mimickers, looking at in favor of SCAD, if it's pregnancy, not responsive to intercoronary nitrates, has systemic arteriopathy or healing, and then those individuals who have a non-acute presentation. The vast majority present with acute coronary syndrome. We've seen a few that have presented with angina, and they probably had an ACS several days prior and then did not, and it was missed or did not seek care. So this was real custom M&Ms from a patient who celebrated her 60th birthday after having survived a SCAD. But why is SCAD bad? And what did we learn with early intervention? So it is gospel that you go in with, particularly with a STEMI, and you've got that artery open in 90 minutes, right? So what we can see is, particularly with intramural hematoma, is this image, and it's an older image, but it's one that I think says thousands of words. And so you see that SCAD, there's actually decent flow there on panel A. They put a stent in, and what you see is it propagated that intramural hematoma. So you have that little beak of an obstruction, and then another stent, and now you're up in the left main. So that is one scenario among others, such as not being able to wire the dissection at all. So I think in that initial management of acute SCAD, remembering that there's a primacy of conservative management, because there is a 30 to 40% complication rate with PCI. But some of these folks, they are they have high risk anatomy, they have hemodynamic or instability or ongoing chest pain. So some things to keep in mind if you're going to work through an intervention is the goal is to restore flow, not seal the dissection, not make it look pretty. and know that there is that extension risk. So this rubric is from the Circulation, the AHA scientific statement. And so looking at if clinically stable and no high-risk anatomy, and high-risk anatomy has severe proximal two-vessel dissection or left main dissection, then conservative therapy, monitoring as an inpatient for 3 to 5 days, and I'm going to tell you why we extend that. For that middle group, considering CABG, but conservative therapy could still be considered, particularly if they're stable. And if they have active ongoing ischemia, we're up in, it's a rock and a hard place. So urgent CABG, if available at your center, or consider PCI. So this group, the UK, Dutch, and Spanish registries actually looked at PCI versus conservative in indications. So what they found is when they were up against a wall, and particularly in those with, TEMI zero flow, they improved flow 80% of the time, but again, kind of 39% complications, 13% were severe. They had more stents than planned, stent length than planned, but longer term outcomes. So I think this is a reassuring study that was published last year that said, if you have to do PCI, expect complications, but longer term is appropriate. Now, why might we want to keep patients in the hospital who we don't intervene upon? So inpatient SCAD care, holding anticoagulants, obviously if they get PCI, using dual antiplatelet therapy, usually starting beta blockers and aspirin, and manage symptoms with nitrates, calcium channel blockers. Our group and several others have identified a dissection extension risk early of 4 to 10%, and it is higher in those with intramural hematoma, suggesting an outside-in sort of approach or etiology of SCAD. So very few happen after 5 days. So in those, even those who are doing quite well, we observe in hospital. It's obviously much easier to get them back to the cath lab if they're in a hospital bed as opposed to sending them home. Patients who do have to return because of extension often have bigger infarcts. So early therapy after treating SCAD. So we talked about beta blockers. The Vancouver group had an observational study that showed that there was associated with a lower risk of recurrence. It is not a strong study, but since we have little to offer these patients, I use beta blockers and I try to keep them on at least a year. They are sometimes poorly tolerated. These are young individuals, often with normal or low blood pressure, and there's a lot of fatigue associated with it. But I do try to get at least a low dose of beta blockers. For those who are hypertensive, really treat elevated blood pressure with the goal being truly normal, less than 120/80 or low. Do not use statins routinely, unlike atherosclerotic myocardial infarction. Reserve that for prevention of atherosclerosis. So if you meet criteria for primary prevention, then obviously you want to put that individual on statins. But statins do not have any effect on SCAD recurrence. There was an early paper published in 2012 that was it was our paper. It was a retrospective review that the reviewers asked us to look at medication, and we unexpectedly found a very small negative effect from statin use. We and Jackie and England have not reproduced that. We think that was just because of small numbers. So it doesn't harm or increase the risk for recurrent SCAD, but it doesn't prevent it, unlike atherosclerosis. So any other treatment should be for non-SCAD indications, PCI for their heart failure, for angina, or for depression. There aren't any other SCAD drugs. We recommend, if they are on hormones, that they stop oral contraceptives and postmenopausal hormone therapy, and stop triptans. There is a disproportionate prevalence of migraines in this patient population. Many are on triptans. There's some evidence that triptans may increase the risk of SCAD compared to other migraine medications. And fortunately now, compared to even 5 years ago, there are far more migraine medications to offer patients. So there's some controversy about early antiplatelet therapy after conservatively managed SCAD. So we're going to put dual antiplatelet therapy on all patients who got a stent. But the current guidelines is that you use DAPT for a full year after myocardial infarction. And is that true for SCAD? And I think there's some real good reasons to question that, because if we think about it, atherosclerotic plaque, that is a clotting event. So using antiplatelet therapy makes incredible sense. On the other hand, if we think about intramural hematoma, SCAD is largely a bleeding event. So should we be doing this? So should we use aspirin alone versus dual antiplatelet therapy? The reason people have advocated dual antiplatelet therapy, because it is standard, because there has been observed on MRI some MVO. But a recent study out of Spain and Italy, the DISCO SCAD registry, actually looked retrospectively again at aspirin versus dual antiplatelet therapy, and found that the early occurrence of non-fatal MI, including recurrent SCAD and unplanned PCI, were 3 times more likely in those who were on DAPT. And it was really an early thought. So even those of us who said, well, we're not going to do a year of DAPT, but maybe 30 days, I am concerned that we may be causing harm to some of those patients. We do not see thrombus very often in SCAD. And so I think at least thinking about no antiplatelet therapy, because intramural hematoma is frequent, luminal thrombus is vanishingly rare. And in fact, if you see it, you should think about a different diagnosis. And so evidence is lacking. The consensus is aspirin alone for 30 days, then aspirin alone or nothing. I think most of us would use aspirin early on, but this is evolving, and I am de-prescribing aspirin in a lot of these folks. And if they're past, and I do not use dual antiplatelet therapy in these patients. So in terms of outcomes for these folks, dissection healing without intervention occurs in 60 to 100% and frequently within the first month. Survival is excellent. I mean, they're a younger group, but even age compared to atherosclerotic disease, they have a good long-term survival. But the outcomes and morbidity is significant. So several studies have come out with ranges from 10 to 25 or up to upwards of 30% recurrence rate. All of them are using different time frames. But if you put them all together, what I quote patients is you have a recurrence rate of about 2 to 3% per year. I say that because 25% patients here, I have a 1 in 4 chance of having another SCAD like today. And so giving them that time range. The other challenging thing here is we don't have any risk stratification as of yet. So individuals, I imagine there are individuals who have virtually 0 chance of recurrence, and we certainly have patients who've had 5 and 6 recurrent SCADs in different vessels. And the other question that we don't have an answer for, but I think is important, is this like a breast cancer, where if you have not had a recurrence in 5 years, you're kind of home free? Our gut feeling is probably this is spread out over a lifetime, or at least, for several years, and probably there isn't a tipping point where the risk goes down, but we don't have those data yet and are hoping we'll get that from our registry and others. Dissection typically occurs in a different vessel. And I do have one patient who's particularly unusual, but she's had 8 or 9 SCADs. It's difficult because she hasn't actually gotten an angiogram for every one of her troponin bumps. And they have been in different vessels. I think it's important not to do revascularization thinking that you will reduce the risk of recurrent SCAD, because it happens in a different vessel on average. So let's get a little bit more in the weeds about managing these patients, because that's where the art, I think, comes in. So it's estimated that well over 50% of patients after SCAD, whether treated with PCI or conservatively, have chest pain after SCAD. Some of it's pretty clearly ischemic. They take nitroglycerin. Obviously, if it's angina that comes with exertion, then likely they should have a full evaluation, stress testing, and everything. But it's hardly any of these patients haven't made at least one visit back to the emergency department for chest pain evaluation. Early on, some of this chest pain is likely, we think, because of doing angiograms for these patients, is maybe more likely due to the tear itself. We talk about aortic dissection being a very painful event, and some of these patients have reported an episode of pain that is a ripping or a popping pain, even several days before presenting with myocardial infarction. So some of the chest pain may be chest wall, non-cardiac, might be due to the SCAD, but it also may be a new SCAD. So we have to evaluate it. I think the other recognition, because cardiologists too often have said, I've never heard of that, but this is a largely reproductive age individual group of individuals. So they have menses, and many of them report catamenial angina. So they'll get chest pain, ischemic pain that responds to nitrates for a day or two before they start their period, and usually by day 2 of their period, it's gone. And you can approach that by using antianginals during that, but at least acknowledge that you've heard of it. You really need an individualized approach. Some of these folks will do a stress test because they have more typical angina, and we may want to take them back to the cath lab. The coronary CTA is a good way to avoid taking them back to the cath lab, because although you won't see the distal coronaries, you will know that the proximal ones are open. I have used, particularly those people who have passed a stress test, I've said, have you taken a nitro for your chest pain? And many of them have mental stress induced chest pain, and they say, yeah, I take it, but they pass a stress test, they go 12 mets. Those are individuals who may benefit from long-acting nitrates or calcium channel blockers, and for their microvascular or large vessel spasm, we do coronary angiography, but it is not the first approach, again, because of the concerns about iatrogenic harm. So this was a rubric from the circulation, and basically, so if they have non-exertional symptoms, and consider empiric medical management, but also looking for non-cardiac causes, and the differential can be a number of things. So one of the other parts that we learned about SCAD, and Jackie saw in our group, sort of made the observation coming at it from 2 different angles right around the same time. So in our initial series, which was 87 patients retrospective, 16 of the individuals had femoral angiograms, and 8 of them looked like the individual on the left. So we said, wow, that seems like 50% of those who they looked at their femoral arteries had AVMD. And what Jackie found is coming at it from a different angle, whereas a group of FMD patients seem to have a higher rate of spontaneous coronary artery dissection. So although we don't know the full extent, but we know that this extracoronary arteriopathy, which is FMD and associated conditions, definitely associated, probably causal, hasn't reached the research bar for that. FMD is probably present in over 50% of these individuals, and some type of extracoronary arteriopathy in over 70%. We have just saw a patient yesterday who had never had a clinical event, but had evidence of prior bilateral carotid dissections and fibromuscular dysplasia in other arteries. And even the sort of undulating aorta and tortuosity are seeing signals. So what we recommend is, 1, a good clinical history to see if they've had any symptoms, and a one-time arterial screen brain to pelvis. We use CT angiography. We do we have a special protocol, which has overcome some turf issues between our neuroradiologist and our body radiologist. 2 injections, arms up, arms down. We do head and neck and abdomen and pelvis in the same study, CT angiogram. We don't do the chest in that particular scan. 1, most of these folks have had a chest CTA during their evaluation for chest pain, and the yield is very low for chest. So looking at that. So the other sort of myth that has been perpetuated, and I say myth because I feel like this was a study that helped address that, is the association of SCAD with autoimmune conditions. Thinking about this is a predominantly female disease, as are many autoimmune conditions, but we really, in seeing large volumes of SCAD patients, we're not seeing patients with newly discovered autoimmune conditions. after SCAD. Somebody had rheumatoid arthritis and they had a SCAD. So the challenge has been that these are referral centers. So we have the this population-based database where we have been able to capture all of the diseases and medical records of folks in Minnesota, southern Minnesota, and Wisconsin. And so bottom line is there was similar prevalence of autoimmune disease in patients with SCAD versus controls. But there was a rising prevalence. And if you look at the left upper bar, I think that reflects the increased recognition of SCAD over time. So again, you do not need to do a big de novo workup to rule out autoimmune conditions unless a patient has symptoms of that. I wanted to focus a little bit on pregnancy-associated SCAD because there are some different features. One, it is more severe. These individuals tend to present more often with STEMI, proximal vessel, multivessel, left main dissections, more likely to end up with left ventricular dysfunction associated with multiparity and older maternal age, possibly with infertility and possibly with preeclampsia. We're still sort of looking at that. Important to note that the vast majority happen in the first month and of those in the first week. So that's kind of when to have your real index of suspicion. Because of pregnancy-associated myocardial infarction of SCAD, we recommend these folks don't get pregnant. So we say avoid pregnancy because even if your prior SCAD is not pregnancy-associated, you have a risk of pregnancy-associated, the hemodynamic changes and the more severe presentation. So we recommend they use effective non-hormonal contraception like a levonorgestrel IUD, which is particularly useful if they have menorrhagia due to the dual antiplatelet therapy. We cardiologists put them on there. For those who get pregnant, because contraception doesn't always work, or people decide to do that, or plan to get pregnant, trying to get some preconception counseling related to their meds, checking their EF, and having a multidisciplinary team with a vaginal delivery. We did look at women of childbearing age at the time of their first SCAD who had a recurrent SCAD to see if pregnancy seemed to influence that pregnancy rate. And pregnancy after SCAD in this small cohort was not associated with an increased recurrence. So I think that's somewhat reassuring. Actually, the vast majority of patients who have a pregnancy after SCAD are going to do okay. But we've got 2 patients at risk, 1, and 2, often there's another child and the risk to the mother of leaving that. So I think counseling and a conversation with both partners is really important in this. Some other things that we cardiologists may not always think about, uterine bleeding. Some of these folks, particularly when we have to put them on dual antiplatelet therapy, have uterine bleeding enough to become anemic and then causing angina. And so looking at referral for appropriate care for that. Managing menstrual angina. So sometimes we'll just bump up their anti-anginal dose or use it for a few days around that time, or just PRN nitrates. Addressing the FMD and associated conditions, migraine management, avoiding triptans, and realizing that sometimes we are limited in the anti-anginals because these folks have more nitrate intolerance. So we know that the highest risk of depression after myocardial infarction compared to other age and gender groups is women under the age of 60. We've known that for a long time. So that basically is this population. Plus you have an event that often happens in a very traumatic way, when they're with their children, have a cardiac arrest in their foyer. And the psychosocial burden is substantial, and making sure they get in cardiac rehab and have proper psychosocial support. And then many feel the losses of health, reproductive options. The other big question that we address is physical activity after SCAD. So rehab is really important, starting 1 to 2 weeks after SCAD, unless they had a very large myocardial infarction. Left main, you may want to let them rest a little bit longer. We recommend they avoid competitive endurance training, high intensity activity, especially in extremes of temperature. So they say, can I run a 5K, 10K? Yes, but don't race it. We want them to do strength training. These are women. We don't want them to lose muscle mass over their lifetime, but looking at lower resistance and higher reps, and limit their lifting to avoid straining or prolonged Valsalva. I personally do not give a weight limit. I think that that's generally women, and because that's who we're mainly talking about, the average middle-aged woman probably has a weight range that they can lift without Valsalva, somewhere between 20 and 50 pounds. I don't want to tell the woman who can do that safely at 40 pounds that her weight limit is 20, because that may have impact on her employment or her being able to do things. So I spend a fair amount of time in the office talking about what that means and that they need to find their limit and to use good lifting techniques. We aim for good blood pressure control over a lifetime. So we know that the demographics of blood pressure in women is that between the ages of 55, 60, and 70, they are going to have a bump in blood pressure, probably up to 10 millimeters of mercury or higher, just because we live in Western society. So I actually talk to patients about, I want this over a lifetime. I would be, even if they have normal blood pressure now, I would be more likely to treat you as you age, and then providing support for the patient and family. Consider medical genetics referral. I say consider because there is no SCAD gene. So in this early report back in 2016, it was our first 5 familial cases in about 400 enrollees. So it implicates both recessive and dominant modes of inheritance. That when we, and Mass General has looked at this as well, when we do that aortopathy panel, it's probably more like 4 or 5% will have some identifiable mutation. So the yield of genetics mutation, but do take a family history, because in that individual who has, yeah, my aunt had a brain aneurysm and my dad had X, Y, and Z, or my mother had a heart attack at 45. Those are ones you may want to look a bit more. We do have a DNA repository for which most of our patients in our registry are participating. And we also got trios, so we got the parents of many of them. And at this point, out of about 1,500, we only have about 12 families. So again, quite rare. That's something you can reassure your patients about. But what we are looking at, and this is got to be an international effort, is are there any risk markers, genetic risk markers? And there are a number. So this was a publication a couple of years ago that looked at opposing risk alleles in the factor 1 EDN1 genetic locus. And if you have the A allele, then you're more likely to be a woman and more likely to have SCAD. And if you have the G allele, you're more likely to be a man and have atherosclerosis. So that's been very intriguing, because I guess it's possible that having SCAD may have some factors that that may protect you from atherosclerosis. So a number of susceptibility loci have been identified at this point, and I think we're hoping that with the collaboration with France, Australia, New York, Vancouver, Michigan, Mayo, that we'll be able to come up perhaps with a risk score at some point in the future. So a little bit about our registry. You have one in Canada, so we would welcome any recruits who also, or in addition, wanted to be part of our registry. We've got over 1,500. They are all angiographically confirmed by my colleague up there, Dr. Rajiv Gulati or Patty Best. We look at their imaging, medical record review. We send out a ton of questionnaires that are both retrospective and prospective. We ask for a personal SCAD narrative. Remember, this is we don't see these patients. I mean, I have a lot of these folks end up coming to Mayo for a clinical visit, but many of them, it's truly a virtual registry. So we don't have that history that we can draw upon, and that helps pull together the registry. We've looked at some perspective and practice evaluations, some echo studies. We've had some follow-up questionnaires related to pregnancy, PTSD, effect of COVID. And our clinic, when I'm in clinic, I'm seeing multiple SCAD patients per day, and we're looking at addressing this. So continuing to try to learn from patients. Patients seem very eager to and willing to participate in the research, largely because they've had the experience of their physicians caring for them, saying, I don't know, I don't know, I don't know, and they're looking to try to improve that. So there are resources for your patients, and I would just say that WomenHeart, although it's a US-based organization has some great resources, and there actually is at least one WomenHeart champion, Carolyn Thomas, who went through the training for that. There are Facebook pages for patients with SCAD, and there's our research page if you have, and there's information for both patients and for referring docs. So to summarize, we're going to continue to see more SCAD. I mean, there's awareness, intravascular imaging, all of those things. We need to maintain our index of suspicion because these are patients that don't look like heart attack patients. The correct diagnosis is even more important because we need to manage them early on and probably long-term different than our ACS guidelines would tell us. You're going to see them again and again after their myocardial infarction because the burden of recurrence and chest pain and other things are very high. Remember the strong association with systemic arteriopathies. Aim for normal blood pressure, and we'd be happy to see your patients in our research. And with that, I will end my show and would be happy to take any questions that have come up. Thank you very much.
Thank you very much, Dr. Hayes. This was really a brilliant overview. You left no stones unturned. I very much enjoyed it. They have some congratulatory comments on our QA chat boxes. So thank you so much for this. I have a million things I want to pick your brain on, but in the principle of altruism, I'm going to move on first to our audience because there are already a couple of questions there. I see Dr. Mike Frosho is one of our interventional cardiologists and our cardiology fellowship program director. He has his hand up. So Mike, do you want to unmute yourself and ask a question to Dr. Hayes? Or perhaps, Kelsey, can you unmute Dr. Frosho?
Yeah, he should be unmuted here.
I still see him as being muted. And I don't think I have the ability to unmute. So as maybe we try to sort out the unmuting of Mike, let me move on to the Q&A box. So there's a question from Monica Sangavi. For women presenting with VFib arrest in the setting of SCAD, what is your recommendation regarding ICD?
I think that's a great question. And it gets to a bigger issue is I have observed these are young women often. So they look like our sisters or our daughters or our wives, and it's sort of horrible. And some of them, I think, get over-treated. And so I think that just like we have a huge amount of data that says if somebody has a normal EF after a myocardial infarction, does not have left ventricular dysfunction, and has their VF during an ischemic event, that we don't put an ICD in them. But we do see that patients are getting ICDs with its accompanying psychological burden and potentially procedural complications. So I generally follow the same guidelines as I would for any other patient who had a myocardial infarction. I do have one patient who, she's from North Dakota, who has had 2 SCADs, and her second one, she did present with a VF arrest, so we elected to put an ICD in her. But the vast majority are not going to need it, and I think I wouldn't want to put an ICD in a woman who just had an ischemic event at the time of her myocardial infarction. But I think we need better data. Mass General has published some on that, just observing who gets it. And there were a number in their cohort that got it for not current indications for ICD. And I think it's like, let's protect this person who looks like my daughter.
Thank you for that perspective. Mike, are you unable to unmute yourself by now?
He's lowered his hand, so I think it might have been an error.
Okay, well, feel free to type in your question too, Mike, if you wish. I see another hand up by Dr. David Burney. He's one of our electrophysiologists and our incoming chief of the Division of Cardiology as of next month. David, can you unmute yourself?
I think so. Thank you, Dr. Hayes. That was a wonderful presentation. Really, really fantastic. And I was interested, I have an interest in cardiac sarcoidosis, and it's often listed as one of as a cause of SCAD, and we actually looked at our big registry, and there was only one case. So I think that speaks to your comment about the autoimmune diseases, being quite rare. My question is, you talked a lot about registries and retrospective data, but is there any data from RCTs, or is there any RCTs planned or ongoing in this area?
Yeah, I can say that in the Europe Collaborative is trying to pull together a prospective trial looking more at early treatment. So looking at looking at the aspirin and beta blocker question. As you might imagine, prospective trials in a condition that, even if it is more common than we thought, is still pretty uncommon, have been pretty challenging to put together and fund. But we're looking at that, and obviously we are limited almost entirely to retrospective. Now that's very strong, but it's mainly hypothesis driven or generating, and so you make a great point, and I think there's a number of us who are looking to how can we work together, and most of us are working together, particularly around the genomics, to perhaps be better and perhaps be bold, because that I think it's really hard for most cardiologists to send a patient out of the hospital after a heart attack with no medication or only on metoprolol after a heart attack, because that's so counter to every guideline that we have been taught. But maybe that would be best for some of these patients. And I think having some additional data would be very helpful.
Thank you. Thank you, Sharonne. I'm going to go back to the Q&A. There's a question by Dr. Girish Nair. He's our chief of electrophysiology. How do you counsel patients regarding screening of children and relatives of SCAD survivors and their risk of SCAD? A question that we get all the time from our patients.
Yeah, so it is a really common question. I say the most common time is, I've got a 45-year-old woman who's, and she's got reproductive age daughters. So she's very concerned about them. Because familial FMD and familial SCAD is so vanishingly rare, I think the main thing we should do is reassure them, right? This is a sporadic event, and I do not think that at this point, in the absence of, certainly there's no genetic testing that would be warranted unless mom or dad had a genetic mutation. I think that's a more rational thing for the patient to get genetic, whatever genetic testing we have available, which would implicate it. But I do not think there should be, CTAs of these healthy young people. So my main approach is to be reassuring, because, and I say, we've got 12 familial cases out of 1,500. It's really rare. And I'm not saying it's not a legitimate concern, but your girls should go ahead and have a baby if they want to. Don't worry overly.
Mm-hmm. Perfect. And very much mirrors what we've been telling patients. So that's great, because we do get that question all the time. I'm going to change gears. There's a question from Dr. Neville Susskind about rehab. Very important to demedicalize rehab, especially for this cohort. Yet the guidelines for rehab recommend not exceeding a systolic blood pressure 130 at exercise. This is impractical, especially during virtual rehab, during this focus at the time of the pandemic. Do you have any advice against, he mentioned here the blood pressure, but you also mentioned the weight lifting, which is very impractical for a number of women, especially the ones that had peripartum or pregnancy-related SCAD. They blink and their baby is already 20 pounds, right? So how do you adhere to these published guidelines?
Well, those are, we don't use those guidelines, I would just say. We use the guidelines for cardiac rehabilitation, which indicates we should individualize our cardiac rehab for the individual. And I think the harm that comes from arbitrary cutoffs, particularly for these young people for which most of the guidelines were not developed, can harm them, because what it does is it either makes them afraid, because every time their heart rate goes over 130, they think they're going to die because their doctor told them not to do it, or they drop out of rehab altogether because they say, look, I know I can do this, I want to do this, so I'm just going to do it on my own. I see that every day. And so I know that, and I'm not sure which particular guidelines you're referring to. I mean, Jackie has published the results from their rehab. And basically the wording of that is, we think it is safe for them to do X, Y, and Z. That doesn't mean it's unsafe to do more. And I think that's where the individualization, I have patients so in our cardiac rehab, we actually do interval training with our cardiac rehab patients. We don't have them do truly the very high intensity. We also do Tai Chi, we do other things, and we use perceived exertion and not arbitrary. And again, that's how I coach individuals about lifting. I don't say 20 pounds. For some women, it might be 15 pounds, right? Because they're frail, they're, they're weak. But this is what I say to patients in the office. I say, I'm fit, but not particularly strong. I can lift a 40-pound bag of softener salt, really concentrating on my breathing and just barely. So if I'd had a SCAD, I would keep my weight limit under 35 or 30 pounds. And so that's a real life sort of example. And I say, if you can just pick up your bag of groceries that weighs 40 pounds with no effort, you shouldn't be worrying about the 40-pound bag of groceries.
That's a really great point. And then the individualization is the key point here, because no woman is like the other. And in the interest of time, I know we are a little bit above time, but I didn't want to miss the opportunity to also ask an interventional related question from Dr. Michel Lemay. He said he really enjoyed your talk, and you emphasized the difference in management between atherosclerotic ACS versus SCAD. What is your imaging approach for a proximal lesion? Are you, Michelle, just to clarify, are you requesting specific guidance regarding like a type 3 SCAD when you may be on the fence about which kind of pathophysiology you're dealing with? You can unmute yourself, Michelle, if you can. Or maybe he can't. Okay. Okay, I see his name popping up. Can you unmute yourself, Michelle?
Yeah. Can you hear me now?
Yeah,
Perfect.
we can.
Yeah. So I'll give you an example. We had a patient that presented with an ACS and had a proximal LAD lesion. It was deemed that this was SCAD, and because the patient was relatively young and was taken off the table. And later on, we went on to get a CT angio, and we couldn't tell whether this was SCAD or if this was atherosclerosis, but there was atherosclerosis in the right coronary artery. And then we went back, brought the patient back, and we imaged with OCT the proximal LAD, and it was clear that this was not SCAD and was just garden variety ruptured plaque from atherosclerosis. And you can see the impact of missing atherosclerosis in this case, denying the patient DAPT, and then atherosclerosis prevention with statins. The treatment is basically very, very different between the two conditions. So the question relates to, how do you deal when you have only something very proximally and you don't really know whether this is SCAD or not?
So you make the point of why being certain at the time of the initial diagnosis is, so 2 points. One, that would be if we can't tell angiographically, you could do what you did, i.e. coronary CT after it, or intercoronary imaging and really trying to sort it out. I see a number of patients who are referred elsewhere, and so I've only got retrospective, and we could do another angiogram now 3 months out or whatever, but in those patients, I tell them for now until we know, I am going to cover both bases. I want you on dual antiplatelet therapy, and I leave you on a statin because that's not going to harm them much, maybe dual antiplatelet therapy. But I think the point and the case that you make is the risk of overdiagnosis of SCAD just because, quote, they're young. And we've seen embolus/thrombus, which in a young patient, which is considerably less common than SCAD, but being called SCAD, and they haven't had a thrombophilia workup, and then they have another thrombotic event. So again, I think that case, probably we'd use intercoronary imaging, but if we didn't, then the other way would be to leave them on atherosclerotic treatment and then go back and re-image with that CT in a month or two, because by that time, if it's SCAD, it should have disappeared.
Yeah,
That's great.
that's a good advice. Hey, I know it's late. Can I just add a little bit to Michelle's question? How often do you see a mixed picture whether the patient has atherosclerosis and SCAD? You mentioned an older cohort of people, so I presume that some of those have atherosclerosis as well. And likewise, the combination of SCAD and coronary spasm, both of which would have potentially different treatment paths?
Yeah, so we do see it, particularly in the older, and we're quite careful, at least for registry purposes, of calling it SCAD versus atherosclerosis, because we know that an atheroma can rupture and cause a dissection. But in those patients, because I see a lot of people in my practice who are 60, when we do their their arteriopathy screen, they've got plaque. So they're on a statin. I cover both bases. I tell patients, my goal is I'm a preventive cardiologist, and my goal is to have you live long enough after your SCAD so you're at risk for atherosclerosis. I'm going to prevent that too.
Yeah, awesome.
Regarding the spasm, I think I sort of implied it. I mean, we really do think during that early period, and early can be weeks to months, that there's some coronary vasomotion going on because these patients have nitrate responsive chest discomfort.
Yes.
And whether it's large vessel spasm or small vessel, I think we should treat it empirically and not go in and do a lot. I mean, I would love from a research standpoint to know exactly what's going on, but I think going in and trying to test for spasm or microvascular disease is probably harmful outside of a research program.
Thanks, Sharon.
Thank you so much. We are already past the time. We could keep asking questions forever. Dr. Hayes, this has been really a wonderful time and experience to share with you this morning. Now, I know you have to go on to meet with our residents and fellows. They are top notch. I think we enjoyed that meeting. And I think many of us will see you again at 9:30 at our panel discussion. So on behalf of our team, once again, thanks so much for your time this morning. And a reminder for our group today that the next grand rounds will be on March 2nd, Dr. James Januzzi from Mass General. So I'll see you all there. And again, thanks so much, and I'll see you later. Bye, everyone.
Bye.
Thanks again, Sharon. Brilliant talk. And thanks for your leadership and mentorship for people like Thais and others. So
Thank you. Bye-bye.
thanks.